Hi, I'm Pat Anderson, editor of MIMS Learning, and I wanted to tell you a little bit about the MIMS Learning subscription. This annual subscription gives you full access to exclusive subscriber content, ranging from clinical reviews to extended learning and recordings of our webinars. So come and check it out. If you take out a subscription, you'll find that it gives you stimulating learning, keeps you up to date on all the hot topics, and helps you with your appraisal process. So have a look today at the MIMS Learning subscription. You'll find it'll really add value to your learning. Hello and welcome to the Clinical Update podcast, a podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I have with me today our medical editor, Sangeeta Krishnan.
Hello.
In 1967, Peggy Lee sang "You Give Me Fever." She went on to explain that this was both fever in the morning and fever all through the night. The Bee Gees were a bit pyrexial as well, suffering particularly with night fever.
Yes, and I think they gave John Travolta quite a bad case of Saturday night fever in 1977.
They certainly did. So as you've probably guessed, today we'll be looking at fever in adults and children, its possible causes and red flags to look out for. Causes range from self-limiting illness to life-threatening disease. We'll have a look at some of the learning materials on MIMS Learning and what GPs should have at the front of their mind when dealing with this key symptom encountered in primary care. First of all, to recap, fever is a symptom of an anti-infection defence mechanism whereby a higher temperature set point for the body is triggered in the hypothalamus. This leads to a feeling of cold or chills and a rise in body temperature compared to normal.
And a great topic, given I'm just recovering from it this week. There is no agreed upper limit for normal body temperature, although it's generally thought that a temperature of 37.5 degrees centigrade constitutes a fever. In older, frail adults, though, normal temperature may be lower, so they may have a fever even if they have a temperature of 37 degrees.
On the MIMS Learning website, we have a module by GP Dr. Pipin Singh on red flag symptoms associated with fever in adults. He reminds GPs that fever in itself is unlikely to be the presenting symptom, but is likely to be discovered when gathering information about another presentation such as pain, swelling, headache, respiratory symptoms, and so on. So there's a puzzle to solve regarding the cause of the fever, and there must be a feeling that you don't want to miss the most serious causes, which include, but are not limited to, sepsis and malignancy.
Yes, that's right. And we will discuss sepsis later, but for now, let's go through the red flags associated with fever that should alert GPs.
The red flag symptoms in Dr. Singh's module are arranged by category. Firstly, the presence of any of the following should get the alarm bells ringing. An indwelling device such as a chest drain, catheter or PEG tube, obvious redness to the skin, recent exposure to HIV, use of immunosuppressants such as steroids or disease-modifying anti-rheumatic drugs, or skin breakdown such as pressure ulcers in nursing home patients, or leg ulcers which might be arterial or venous. Where nursing home patients are concerned, they may be frail, and the degree of frailty will be a factor in the GP's decision-making, along with their capacity to make decisions about their treatment. Dr. Singh talked in detail about patients in nursing homes in a previous episode of this podcast, which is so well worth a listen. And we have, of course, recently covered frailty as well, both on our website with a clinical review by Dr. Alistair Robertson and in another podcast interview.
Yes, and we have learning materials on leg ulcers written by Dr. Matthew West, where he talks about when you would start antibiotics empirically without waiting for microbiological results. Fever or another sign of systemic upset, such as tachycardia, would be a prompt for starting antibiotics, as would the sudden onset or progression of symptoms such as inflammation, pain, erythema, exudates, and swelling. The location of the patient and their ability to access services may also influence your management of suspected infection in a wound such as leg ulcer or pressure ulcer. For example, if the patient is vulnerable or based in a rural area, or it's a bank holiday weekend, for example, you might want to put antibiotics in place sooner rather than later.
That's a very practical point. So fever is a key thing to look out for in the scenario of a suspected infected leg ulcer.
What else accompanying fever should get those alarm bells ringing?
Well, quite a lot of things. Regarding things that have happened recently, which is one of Dr. Singh's categories. So if your patient has just come back from abroad, has recently been pregnant, has recently had chemotherapy treatment, or recent intravenous drug use, all of those factors would give you avenues to pursue. And new onset symptoms of various types is another category that would again give a GP reason to consider seeking urgent specialist help. The list of these is not exhaustive, but includes the following in the presence of fever: new onset swelling of a joint, limb, face or abdomen, new onset headache with or without focal neurological symptoms or with associated photophobia or neck stiffness, rashes, in particular non-blanching petechial rash, significant low back pain, urinary symptoms such as dysuria, hematuria and loin pain, bloody diarrhea, vaginal discharge in association with lower abdominal pain and any history of recent pregnancy, and testicular swelling.
And we have a new module on testicular pain and lumps, again written by Dr. Singh, that's just come out. It's well worth having a look at to help you structure your consultation and adopt a sensitive approach that addresses your patient's concerns.
Thanks, Sangeeta. So now let's touch on the last category of red flag symptoms mentioned by Dr. Singh to look out for in the context of fever. And these are persistent symptoms, such as cough, shortness of breath, hemoptysis, fever lasting over 3 weeks with no clear cause, night sweats lasting more than 6 weeks, and neck swelling or swollen neck glands lasting more than 6 weeks. Unintentional weight loss is another longer lasting symptom that should prompt consideration of referral. Some of these persistent symptoms are clearly associated with cancer, or could be, and cancer is the subject of our current editorial campaign entitled Patient Presentation Pathway for Cancer. So do check it out. We'll add a link to our campaign page in the notes for this episode. So we could easily take up the whole podcast talking about the possible causes of all these symptoms from all these categories, because there are just so many. If you have a look at Dr. Singh's module, you see a really good list of possible causes for the fever, ranging from cancer, ENT infections, pelvic inflammatory disease, acute respiratory infections, septic joints, and tropical infections, to name but a few. And that list should help to refresh your memory. He also talks about taking a good history, a good assessment and examination, and conducting investigations as appropriate. Finally, in a section about when to refer, he says that a 999 response is likely to be needed if septic shock is suspected. Septic shock is, of course, a complication of sepsis, and it can cause organ failure and other life-threatening complications.
Yes, let's talk about sepsis since it is so important. There are numerous tools for recognizing sepsis, such as the UK Sepsis Trust and the RCGP Sepsis Toolkit. The National Early Warning Score, or NEWS2, can be used to assess illness severity in adults. It can be used for communication of illness severity to receiving hospitals. A score of between 1 to 4 is considered low risk, whereas a score of over 7 puts a patient into a high risk category requiring continuous monitoring. Notably, where temperature is concerned, a temperature of between 38 and 39 degrees gives a score of 1. A temperature of over 39 degrees scores 2, but, and this is worth remembering, a temperature of under 35 degrees scores 3 points.
That's interesting. Why is that?
So apparently it may be an energy-saving strategy deployed in the presence of more severe sepsis when the body's energy supplies have already been depleted.
So hypothermia, if present, may be a sign of greater disease severity.
That's right, and that's why hypothermia scores higher on NEWS2.
So what do GPs need to look for in a suspected case of sepsis?
We have a module that summarizes the NICE guidelines on sepsis, written by Dr. Ivan Coe. This has a handy table on the NEWS2 system showing factors such as respiration rate, blood pressure, and pulse, along with temperature. In general, the extremes can carry a score of up to 3. So in terms of respiratory rate, very fast or very slow, oxygen saturation, very low or very high on oxygen, very low or very high blood pressure, and very slow or very fast pulse. Dr. Coe says that as well as using the NEWS2 system, clinicians should conduct an examination assessing for the following: a mottled or ashen appearance, cyanosis of the skin, lips or tongue, non-blanching, petechial or purpuric rash, any breach of skin integrity, such as cuts, burns, or skin infection, any other rash which might indicate a potential infection. He recommends asking patients if they have recently presented with signs of suspected sepsis, given that patients with repeat presentations for medical attention are at higher risk of having sepsis. Some individuals, such as patients with spinal cord injuries, may not develop a raised temperature. Changes in cognitive function may present as changes in behavior or irritability in both children and adults with a learning disability or dementia. If you do suspect sepsis, immediate hospital transfer is recommended.
There are some caveats around the use of the News 2 score, though, aren't there?
Yes, Dr. Coy says that News 2 is not suitable for under 16s, those who are or have recently been pregnant or are in an acute setting, including an acute mental health setting.
So you've mentioned under 16s. Let's focus on fever in this age group now. We have another red flags module by Dr. Singh on fever of unknown origin in children. A common presentation in primary care and one that must have untold journal articles and book chapters written about it.
If not a song yet.
Not yet, as far as I'm aware, but maybe we could write one. Of course, fever in a child causes a lot of parental concern, particularly when you get those spikes of very high temperature.
Yes, and febrile convulsions or febrile seizures are fairly common in children under around 5 years of age. These occur when a child has a high temperature. Witnessing one can be a frightening experience for a parent, even if they last on average 2 to 3 minutes, and in most cases they do not cause lasting harm.
So our red flags module on this topic has 2 lists of red flags, one for the under 5s and one for the 5 to 16-year-olds. In older children, red flags include new onset headache, seizures, rash, vomiting or diarrhea, joint or facial swelling, abdominal pain, photophobia or neck stiffness, new onset cough, and many, many more. And in younger children, in addition to the ones listed for older children, red flags accompanying fever might include decreased fluid intake, decreased urine output, persistent temperature, irritability, cool peripheries, bulging fontanelle, reduced interest in external stimuli, and new onset seizures. I'm not really doing justice to these lists here, as they really are very comprehensive.
There are a lot of potential causes of fever in children, ranging from common childhood illnesses such as chickenpox or tonsillitis to pediatric inflammatory multisystem syndrome, or PIMS, which is a rare complication of COVID-19, and ENT infections, including glandular fever. Also in the list is meningitis, juvenile arthritis, and urinary tract infection. Again, Dr. Singh provides useful pointers on taking a history, systems review, and examination. GPs are still advised that the NICE traffic light scoring system may be useful to aid the decision-making process, although there has been a study in the British Journal of General Practice casting doubt on the accuracy of the system. The author said in no uncertain terms that, and I quote, "This system is not suitable for use as a clinical tool in general practice." Dr. Singh says to refer when fever is persistent, lasting over 5 days with no clear cause, there is a non-blanching rash, the diagnosis is not clear, but the child is unwell, or if you suspect septic shock or meningococcal septicemia. Detailed safety netting may be needed if the child is being sent home.
Thanks, Sangeeta. Yes, safety netting is vitally important, and also good documentation in case the patient or the parent comes back and sees a different GP next time. So, what have we learned today? I think the key takeaways for me are firstly that there's a very wide range of red flag symptoms associated with fever in adults to do with immunosuppression, frailty, recency of onset or persistence of symptoms. That means there's heavy lifting to be done in terms of history taking, examination and investigation. Secondly, in the context of sepsis, an extremely low temperature is actually scored with a higher News 2 score than a higher temperature. Hypothermia is a sign that the patient's very sick. Thirdly, GPs should use the NICE traffic light system for assessing fever in children with caution, as GP researchers have cast doubt on its accuracy, saying it's not suitable for use as a clinical tool in general practice. Thanks very much for joining me today, Sangeeta. Also, just to mention, we have a new webinar coming up which is free to attend. This takes place on Tuesday, 15th July, and it's about how to harness conflict for growth in primary care. Our presenter will be Dr. Farnaz Sharif, who's continually working with NHS teams and couldn't be better placed to advise you on this topic. Please do join us then. It starts at 7 p.m. for an hour of really different, really useful learning. Don't forget you can claim CPD credits for listening to this podcast. To get your certificate along with key learning points, you just need to go to our website. You've been listening to the MIMS Learning Clinical Update podcast produced by Jude Owen. I'll hope you'll join us again next week when I'll be interviewing Dr. Tony Hazel about weight loss drugs and women's health, contraception and HRT. This is a hot topic at the moment, so I'm really looking forward to it. We'll see you then.